And then now it's time to see your patients. You're going to go to bedside and see your patients. So this is where you're going to start collecting your subjective data. And so always introduce yourself and say your name repeatedly. Even if they recognize you, even if they say your name, you want to know you want them to know who their physician is. And the interns really are the primary physician for this patient. They spend the most time with the patients. They know their patients better than anyone else on the team. And how I always like to start this part of collecting my subjective data is just asking how they are feeling based on what they presented with and how it compared to the previous day. So if someone came in with shortness of breath and cough, oh, are you still feeling short of breath? Are you still coughing throughout the night? If someone's coming in with chest pain, ACS rule out, any chest pain overnight, any chest pain now. And then if someone, for example, came in with cellulitis, how's your pain? How does the rash look and feel to you compared to the day prior, right? You always, any complaint that they have given you that day, specifically if it's the reason for their admission, please ask them how they feel about it, if it's improved, if it's worsening, if it hasn't progressed at all. This is very important. And then you get to the physical exam part. And I'm gonna just really stress that everybody coming in on their very first day gets a full physical exam the day they are admitted. It doesn't have to be like very detailed. I know we're all busy on call days, have lots of admissions, but everyone should be checked from head top to bottom, right? And so I usually always start with making sure they're alert and oriented. I listen to their heart sounds. I listen to their lung sounds. I examine their abdomen, making sure it's not tender. I listen to the abdomen, make sure their bowel sounds. I look at their lower extremities, make sure that there isn't any lower extremity edema. And then I just look at their overall skin and make sure that there's not any rashes or anything concerning. And then finally, the neuro exam, I do not leave without doing a neuro exam. And so I'll make sure that they can move, like their extraocular muscles are intact. Especially in the ICU, I will check the pupils every single day. And then the strength for all extremities. I will do strength testing on all extremities. Once I have a baseline for this, and I've done my full physical, I have a general idea of what that patient looks like, right? So they're being admitted looking like this. And so if they worsen or get better, I have examined it. Or if suddenly there's a different complaint that comes up, I have a general idea, for example. Let me give you this. Like if someone came in, didn't have any neuro deficits, you did all your strength testing, and then suddenly at 3 p.m. you go and evaluate them. And initially they were alert and oriented, and now they don't know where they are, and they really can't raise their right hand, and they don't move they're not moving their right lower extremity as much. So that's why it's really important to just have a baseline idea of your patient. And then on all the other days, so everyone full physical first day, all the other following days where I'm rounding on my patients, unless they bring up new complaints, there's usually 3 things that I routinely do. So I always examine the system they presented for, right? So if they are heart failure, I will listen to their heart and lungs every day. I will look for JVD every day, and I will look at their lower extremity and see if their pitting edema is improved, always. If they're coming in for example, say pancreatitis, you always want to palpate their abdomen. You always want to listen for bowel sounds. Say they have an empyema, that was a chest tube that had been placed. Always want to listen to heart sounds and lung sounds, and always look at any drainage, right? Anyone that has tubes or drains or anything like that, make sure you know and are keeping track of how much they're draining. Not only that, but what it looks like, right? Because you're going to be asked about that. Is it purulent? Is it serosanguinous? What is in that draining bag? What's being collected, right? The second thing, so that was the first thing, whatever system they came in for. The second thing is I always, before I leave, will look at their lower extremity, make sure there's no pitting edema, and make sure they're still symmetrical. DVTs are very common in the hospital, so this is just something that I routinely do for all my patients. And then the third thing is I have them move all 4 extremities every single day to make sure that there's no neuro deficits, nothing that I'm missing, that they're able to move their body. Then after you're done with, so you've asked them how they're doing, you've done your physical, you ask the patient and the nurse for any overnight events, and follow up on anything the patient told you. So there's these, especially the important things also here would be like urine output, bowel movements, how much of the diet are they eating. These urine output, having bowel movements, and feeding, those can really, you need all of these to be functioning before you can think about discharging someone. So you don't want to just neglect them throughout the entire hospital stay, and then you're all suddenly, the team agrees, we're going to discharge this patient, and they haven't had a bowel movement in 5 days. And then always be kind to the nurses. And I particularly like to end, like, is there anything that I can do for you or any concerns that you have? Oh, and then we kind of briefly talked about urine output and bowel movement and eating or not. And then at this point, you can go back to your team to kind of pre-round, discuss not only your TERT review that you've done for the objective data, but now you've also gathered your subjective data, right? And discuss with your senior if time allows. And so please keep this in mind. I cannot emphasize this enough. If the patient is more altered than baseline, please tell your senior right away, right? Nobody is going to get mad at you for interrupting, not even interrupting, for like stopping them while they're doing something else. What they will get mad at is if you wait because you think that you're bothering them, or wait until you're rounding with the attending to provide this information and the senior is not aware of it, right? If there's any change from baseline, let your senior know right away. When I'm saying right away is usually I will go in there and I'm very concerned about the patient. I'll go ahead and do my vitals and do my a very brief assessment because I know I want to figure out some things before I go and talk to my senior. And then as I'm leaving the room, I'm either texting or calling my senior if I'm really concerned. And then always want to check Foley's, be aware of lines, be aware of wounds. Always look at wounds, especially, so this is the general rule as well. If the nursing staff is the one that's doing the wound care, every single morning, go ahead and unwrap the dressing and evaluate it. If the surgical services are providing the wound care and the dressing, then I usually just check above and below the wound and just make sure that it's not spreading. And in addition to that, I'll ask the nurse that when the next time the surgical services are at bedside changing the dressing, if she can just please let me know so I can come to bedside and examine it as well. You really don't want to just leave a wound without checking it. All of a sudden 6 days pass by, no one's taken a look at this wound, and now it's deeper and like bone is visible, right?